So good afternoon, everyone. It's a great pleasure to welcome all of you on behalf of EuroELSO. Today we are launching our brand new EuroELSO Webinar series with a session on controversies in eCPR. Now, with this new educational offer, EuroELSO is intending to deliver cutting-edge knowledge to our multidisciplinary community. Top experts in the field will be presenting the latest scientific findings, as well as sharing their practical experiences with us. When I say us, I mean all professionals involved in delivering ECMO therapy. In other words, intensivists, cardiologists, cardiac surgeons, paediatric and neonatology specialists, perfusionists, ICU nurses, and physiotherapists. We are looking into two 15 to 20-minute presentations of our today's experts, who are Belohlavek from Prague, Czech Republic, and Alain from Paris, France. There will be a discussion after the second talk, so please don't hesitate to enter your questions in the online webinar tool anytime during the presentation or anytime thereafter. My name is Schellongowski from Vienna, Austria, and I will be moderating the session, collecting your questions and passing them on to the experts. In case you have to leave early, or you would like to replay the session or recommend it to a colleague, you will be able to do so and download the webinar once it's put online to the EuroELSO website, which is www.euroelso.net. While we are awaiting the presentation of our first expert, Belohlavek, please be advised to not miss the registration for the EuroELSO annual meeting held in Prague this year between May 23rd and May 26th. And there will be many more discussions on all ECMO relevant topics there, and we are very much looking forward to meeting you there in person. So for now, please enjoy together with us the first presentation by Belohlavek on the first EuroECMO webinar, Controversies in eCPR. Welcome, Jan.
Thank you, Peter, and hello to everybody. It's my great pleasure and honor to participate on the first webinar of EuroELSO. And our topic is eCPR. Let me talk a little bit about the background and some controversies. We should talk about controversies, and this is a topic for pertinent debate. So what is eCPR? eCPR means continuation in CPR using mechanical device, mechanical circulatory support, and in almost 100% cases, it's veno-arterial ECMO, meaning you insert a cannula into the inferior vena cava, right atrium, take out the blood over the pump, over the oxygenator, back to large artery, making a full veno-arterial bypass. And you can see on the right-hand side a patient who is dependent on VA ECMO after a prolonged CPR at the ICU. On the left-hand side, you can see the cannulation, the arterial cannula laterally and venous cannula medially in the groin of the patient. eCPR always comes into the clinical scenario where you encounter refractory cardiac arrest. And we'll talk a little more later about what is actually refractory cardiac arrest. But let me show you one of my patients. This picture is actually 11 years old. It was a young lady who suffered refractory cardiac arrest, was resuscitated 45 minutes, was brought up to our ICU, and we resuscitated her for next 90 minutes, and she died. And we could not get a rough return of spontaneous circulation. And at that moment, I started to, to think about what to do with patients like this. This particular lady was actually intoxicated by the jackson from the tea she was chewing, and therefore we could not get her heart back. Since that time, we were working thoroughly on eCPR program, and we were trying to train the team to be able to admit a patient under ongoing CPR and to use eCPR for possibly salvaging our patients. And this is, if things work and everything's okay, this is one of our patients who provided consent. This lady suffered out-of-hospital cardiac arrest. She was resuscitated for 73 minutes. You see my slides, actually?
Yeah, and I don't think we see your slides as of now. You will have to, you start the the broadcast.
Okay, you see my slides?
Yes, now it works.
Okay, so this is a young lady, 37 years old, who was brought to hospital after 73 minutes of refractory cardiac arrest. She's had ventricular fibrillations, has been many times defibrillated. She was put on mechanical device. We use Lucas for this. She was put on ECMO, examined, and this is the next day on ICU after she has been extubated. Such a long cardiac arrest always means that the majority of your patients will die. Of course, it's a must, unfortunately. The other thing is that you may encounter a lot of complications. This is another one. This is a young male with refractory cardiac arrest, being resuscitated for 45 minutes. Had acute MI, had acute stent thrombosis in 2 vessels. He got a lot of heparin, aspirin, 2B3As, and you see he's bleeding from everywhere. For first day after 24 hours, he received 15 units of RBC, 16 units of FFR, and 4 units of platelets. And you can see that the patient bleeds from everywhere. So what actually we do, we have a critically ill patient, as you see in this slide, and we have conventional measures which fail. Conventional CPR was unsuccessful. We have to choose the right moment. We have to choose right devices, right scenario, right team, and right place. And we can use the rescue interventions. The problem is, if you use the rescue interventions, it's difficult to prove effectiveness of those rescue interventions. And many times we are doing interventions which do not have a lot of evidence in the literature. So our topic is controversies of eCPR. So let's start with the first controversy, and the first controversy is ethics of what we do. So the question is whether it's ethical to put a patient on a device to extend CPR. We do have uncertain risk-benefit profile in those patients. We are not able to ask them whether they would like to have an intervention like this. Whatever we do, it's high costly. Patients still have a grave prognosis, and we can actually potentially harm our patients. What we can do is, in failing recovery of left ventricle function, which is not rare, the patient is being bridged to nowhere, and we have a very difficult ethical dilemma what to do with the patient. Patients may have prolonged ICU stays, which is disaster for the patient, for the family, and also for the ICU staff. And sometimes what actually happens is that we avert the death with eCPR, and actually we foreclose the chance for a fast and good death. So this is very, very important if you consider to start with eCPR, or if you are doing a eCPR frequently, to be sure that this first major controversy is being handled properly. What about the studies and what about the evidence we have? There is no randomized study at the moment which has been published. This is several studies for more than 16 years. You see not too much patients being included in those studies, the largest one from Japan. And this is important, the time to ECMO. Time to ECMO may be considered to be the same as a time to artificial ROSC, so return of extracorporeal circulation. And of course, with longer times, like here in the Paris study, you get a low survival. If you've got a reasonable time to ECMO, like 44, 49 minutes, the time and the survival may exceed even 30%, which is actually a very successful result. There is 6 ongoing randomized trials in eCPR, one in Vienna. Those patients are randomized for a field CPR versus emergency department ECMO, and patients are being put on emergency cardiopulmonary bypass. The Maastricht Inception study, early initiation of ECLS in refractory out-of-hospital cardiac arrest, conventional CPR versus eCPR at the emergency department. Then the Michigan study, very similar. Then there is a Paris study comparing pre-hospital implantation versus in-hospital circulatory support in refractory cardiac arrest. We are running a, we call it Prague out-of-hospital cardiac arrest study, where we compare so-called hyper-invasive approach. I'll explain later what does it mean or what it stands for. And in British Columbia, again, eCPR versus non-eCPR regions are being compared for patients in refractory cardiac arrest. The second controversy: should we perform interventions with limited evidence-based evidence? That's the question. We at least have to follow a protocol. I just want to share our published protocol for our trial. It's hyper-invasive approach to out-of-hospital cardiac arrest. And hyper-invasive means that we are using mechanical chest compression device. We have used pre-hospital intra-arrest cooling until the time it was available. It's not available anymore. And transport under ongoing CPR to hospital for extracorporeal life support if the patient still has a refractory cardiac arrest. And immediate or early, if you like, invasive assessment with, of course, invasive treatment, which means PCI usually, or pulmonary embolectomy by catheter. And we are randomizing patients in field during ongoing CPR to this approach or a standard approach with a standard conventional CPR. If we look into guidelines, and the last European Resuscitation Council guidelines come from 2015, there is a section on eCPR which stands that we should consider this approach as a rescue therapy for those patients in whom initial advanced life support measures are unsuccessful, or for facilitation of specific interventions, that is coronary angiography and PCR or pulmonary thrombectomy for massive pulmonary embolism. There is also a sentence saying that there is an urgent need for randomized studies. Therefore, I'm really convinced that randomized studies have to be performed for this approach. In view of those guidelines, our hyperinvasive approach uses eCPR as just one of the several stepwise interventions with kind of changed pre-hospital and early hospital logistics, because we have changed our approach to refractory cardiac arrest. We'll talk also a little later about that. So there comes controversy number 3. So were those patients suitable for eCPR? And I will focus on out-of-hospital cardiac arrest population, where they come from. If we look at the cardiac arrest population out of hospital, it's like 50 to 70 per 100,000 annually. Prague has more than 1 million people, so we do have 500 to 700 resuscitations per year in Prague. And all informations we actually do have, and we can believe on our hospital cardiac arrest, are from CPR registries, from large INCAR registry, from the landmark TTM trial. But all those patients who have been enrolled in those sources have been successful ROSC patients, patients who got ROSC in field and were brought to hospital and treated in hospital. But this is only 30 to 40% of all resuscitated patients. And the remaining 60 to 70% usually is dying in the field, and they are pronounced to be refractory and they die. And there is a lot of patients which are actually young or lower age, which have been totally healthy before this catastrophic event occurred, and those patients might be suitable for approach with eCPR. To be able to distinguish and to pick up the right patients, we have to define the refractory cardiac arrest, which is a problem. There's been several studies saying that if you are too short, meaning that if you include a patient into the eCPR track too early, you may miss the spontaneous circulation occurrence. Second, the other side is if you wait too long, like in Paris study, for 30 minutes, you probably lose the possibility to save those patients who might survive prolonged cardiac arrest. So several studies have shown that somewhere around 16 to 20 minutes of CPR, that's the right point, right moment to consider other measures like referring patient to eCPR center for performing eCPR. And there's a recent, several recent analysis, one from Vienna, the other one from Canada, and saying that only 4 to 6% of patients out of hospital cardiac arrest population is actually eligible for eCPR approach. So it's not too much, but it's a certain kind of population which we have to pay attention for. The overall outcome of those patients is very poor. If you see this well-known graph comparing CPR duration, and here you see 15 minutes to outcome, you see the outcome is very poor, somewhere 2% with conventional measures in this study of more than 1,000 out-of-hospital cardiac arrests. The other large study, this is actually a Swedish registry, included more than 19,000 patients, comparing number of defibrillations to outcome. You see that in those patients who need 3 or 4 defibrillations, the chance for survival is somewhere around 20%, and then it declines rapidly. If you go to 6 to 7 defibrillations, we are somewhere around 10%, and if you have more than 7 defibrillations, it goes down below 10%. So with increasing time of CPR, increasing necessity of defibrillations, the outcome of our patients is, of course, very poor. So let's try the controversy number 4. So where should eCPR be provided in out-of-hospital cardiac arrest? Should it be out-of-hospital cannulation? Should it be in-hospital cannulation? And if in hospital, should it be at the emergency room or should it be at the cath lab? We actually perform this in majority of cases in the cath lab. And let me share with you our cath lab, how the setting is. This is a cath lab prepared for admitting a patient with refractory cardiac arrest. You see the cath lab table with a Lucas carbon plate, which can be used for doing the X-ray through this carbon plate. Of course, we have a ventilator, a section device. We use near-infrared spectroscopy for brain saturation measurement. Of course, defibrillator. We used rhinocil before, but it's not available anymore. We need to have ultrasound, both vascular and cardiac. And of course, ECMO, extracorporeal machine, which is right here. And the team usually consists of intensivists, which is coordinating the whole thing, interventional cardiologist or 2 of them, ICU nurse, 2 cath lab nurses, perfusionist, and we use a data manager person just to record everything what happened during the CPR. And to be honest, there's a lot of other controversies. With my limited time, just let me open the discussion, or let me invite you to Prague for EuroELSO, where all those controversies will be deeply discussed. Who should cannulate? Should it be intensivist, cardiologist, or eCPR emergency physician? Should we go first to cath lab after cannulation, or to CT scan first? Should it be TE guided insertion or X-ray guided insertion, and the control of correctness of cannulas? Should we anticoagulate a patient on eCPR, because bleeding complications are very often, and there are centers around the world which don't use anticoagulation within 24 hours after eCPR? What kind of reperfusion solution we should use? What kind of temperature target management? Should we use 33 or should we use just 36? Who is the optimal candidate? Is it a young person with ventricular fibrillation without comorbidities? And how to assure 24/7 coverage in all centers? Because there is studies showing that the outcome is different if the patient comes in during the working hours versus off hours. So that's a matter of a large discussion. And let me conclude briefly that eCPR is probably a viable option for our patients, or a special subset of our patients, but not ECLS or ECMO alone, but the comprehensive approach, including extracorporeal life support, may have an impact on logistics for those patients. We have to bear in mind that patients who need ECLS for refractory cardiac arrest usually have severe unresolvable causes like aortic dissection, aortic rupture, and similar. So we have technology. We still need to define proper patients and optimize logistics. And I'm quite convinced that randomized studies are absolutely necessary. And as Peter pointed out, I'm inviting you to Prague. I'm the chairman of this conference. I would be happy to see you in Prague and discuss all those issues. Thank you very much.
Well, Jan, thank you so much for giving this very concise overview on the topic, and also for sharing with us how you in Prague deal with it practically on the one hand, and on the other hand, for sharing this protocol with us so that we can get a feeling of what will be coming out in the nearer future, so we get some more evidence that we can discuss. Well, I would like to hand over to Alain as the second speaker, and would like to remind you, all of you, to use the opportunity and to put in the questions that you have in the webinar tool, so that we can discuss your questions together with our experts right after the second presentation. Alain, welcome, and let's hear your presentation.
Okay, welcome everybody. It's a great pleasure for me to have you with us today for this first webinar of the EuroELSO. As the chairman of the European Society, I'm very proud that this first webinar is organized today. We choose to discuss a very important point, that the use of ECMO to rescue refractory cardiac arrest, which has been called eCPR. And in the next 10-15 minutes, I will discuss with you some of the issues, as also mentioned by Jan in the past 20 minutes. So first, this is my disclosures. Let you 1 second to go through that. So first question, why should we go to eCPR? This is one very important study also Jan mentioned a few minutes ago about the outcome of patients who had out of hospital cardiac arrest. It's a huge series here of more than 1,000 patients. And this is in an area in the US where there has been a huge investment in the care of severe patients who have cardiac arrest outside the hospital. They have been involved in bystander CPR, in education of the population. So it's probably one of the best places to evaluate the outcome of these patients. And as you can see here, in that series, the survival to discharge was 11%, which is huge. Usually in most out-of-hospital cardiac arrest series, survival is between 5 and 6%. And in that series, the survival with a good neurological outcome was 6%. Once again, which is a very nice results. Jan showed you also that slide, which I think is a very important point here, which evaluated the outcome of those patients as a function of the number of minutes following cardiac arrest. And in that study, we were able to show that after 60 minutes of CPR, there was less than 1% of the population which survived with a good functional recovery. So there is a huge unmet need here because, as Jan mentioned a few minutes ago, there's some young patients with very little comorbidities. We have this kind of cardiac arrest, and probably, surely, some of them might benefit from the ECMO technology in that situation. When they evaluated the predictors of hospital survival, the duration of CPR was always one of the most potent predictor of the outcome, together with age, witness cardiac arrest, the initial rhythm as a shockable rhythm. These are called the Uchstein style variable, which should be evaluated every time you are interested in a series of patients who have out of hospital cardiac arrest. And once again, the CPR time is critical here, as also mentioned and showed in the last slide. Another very provocative study I would like to share with you now. It's a study comparing the outcome of patients who have out-of-hospital cardiac arrest and will receive conventional CPR by either the basic life support team or an advanced life support team. The basic life support team is mainly by paramedics or firefighters, for example, here in Paris, and the advanced is mostly conducted by doctors. In this situation, in advanced ALS, it's possible to intubate the patient, to deliver drugs, etc. So this is the study here. It's a huge series, more than 30,000 cases. And they compare the outcome of patients who got ALS versus BLS. They use very sophisticated stats to do that, what is being called propensity matching strategies, which makes it possible to carefully match cases and control on many pre-hospital and characteristics, demographic characteristics for the patients. And guess what? Guess what? Those who got BLS had much better outcome. And maybe, probably, it was just because it was possible to drive these patients more rapidly to the hospital, and probably the duration of CPR may have been less in this population of patients. So now let's review what are the results of ECMO, of eCPR in cardiac arrest patients for patients who have in-hospital refractory cardiac arrest, where obviously it's much easier to cannulate, because in some hospital now they have been a rescue team, eCPR rescue team, which has been launched. It was the case here in one of the first big series from Taiwan, published just 10 years ago now. ECMO for 59 patients aged 18 to 75. Very importantly, was witnessed in hospital cardiac arrest of cardiac origin. And the decision was made very early in the course of CPR, after only 10 minutes of successful CPR. And in that series, you compare also the outcome of this eCPR population to another group of patients who just received conventional, a match on the propensity score technique. And these are the results here. Those patients who got eCPR had a much better outcome. The survival rate at 1 year was close to 30. It was less than 20 for those patients who got only conventional. This is the second very important point also from that study, is the time from collapse to the time the machine was fully functioning. And this 1 hour threshold seems very important here. Those patients who got eCPR functioning more than 1 hour after collapse at much less satisfactory outcome. In that study, however, when they looked at this population of patients who got good functional neurological recovery, the difference between the two groups at 1 year was not significant. Maybe it was just because of the number of patients included and the power of the study. Now let's review some of the studies for those patients who have out-of-hospital cardiac arrest, in which obviously is much more difficult to get the patients under ECMO. There's many studies published. I'm going to show just this one because as of now it's probably one of the most detailed and very well done studies. It's a study of 53 patients here with witnessed cardiac arrest of cardiac origin, the same population as the population by Chen for in hospital. And this time, the primary endpoint is not just survival, it's survival with good neurological outcome, which I think is very important here. So this is the description of the population. Look here, time from arrest to hospital on average was just half an hour, which is very, very short. It's probably which makes it possible to get good results with eCPR. When looking now at the population who got eCPR, the survival rate at 3 months was close to 30%. it was less than 5 for those who received conventional, which is expected. And looking at good neurological outcome at 3 months, the results are not that good. We have only 15% of the patients who got survival with good neurological outcome was still statistically significantly higher than the patients with conventional, for whom the rate was less than 3%. This is the Kaplan-Meier curve here, clearly showing the benefit of the strategy of eCPR. Of course, there's huge interest for this activity worldwide. These are the latest from the EuroELSO registry, showing a huge increase in the last, let's say, 8 years of the activity, the number of cases recorded in the registry. Survival rate in the registry is very stable over the years, with survival being close to 30% overall. And this is also one of the most important study published on the subject, because it's a meta-analysis of all the studies published in the last 10 years. And when looking here at the results for survival at 1 month, the survival rate is close to 30% with ECLS and was significantly better than conventional. For whom the population and the survival of the population was only 15. Once again, when looking at the most meaningful endpoint, survival at 30 days with favorable neurological outcome, it dropped down to 18, but was still statistically higher than those patients who did not receive eCPR, for whom the percentage was only 7. So now let's discuss real life data. What should be the population of interest? When should we go for eCPR? How? Which results? Jan also mentioned some of the controversies, and actually there are a lot of controversies about all that. These are the latest data from South Korea, a country where there's a huge interest in ECMO overall and also in eCPR. And these are real data from their registry. They have a national registry gathering all the cases. And this is a registry of 320 patients. It's probably at the present time the largest series of patients who received eCPR for out-of-hospital cardiac arrest. And the results are not that good, that's quite disappointing here. When looking at the factors associated with a better prognosis, therapeutic hypothermia was associated with better prognosis, together with early reperfusion therapy, but not ECLS. They try to match and to adjust with different types of confounders, and overall they did not show a benefit of ECMO. This is the conclusion of the paper here. Out-of-hospital cardiac arrest patients who received ECLS did not show better survival outcome than those who did not, which is actually some kind of deception when comparing these data to other data. But once again, the data from the Japanese group are from highly selected patients with a very specific strategy of what is being called scoop and run. The patients with the paramedics very rapidly to the closest hospital to be able to cannulate the patient very, very early in the course of the problem. This is another interesting paper published a few months ago about the impact of the initial rhythm. It's a series of 68 patients from a group in France. And here, half of the population at initially a shockable rhythm, and the other half at the non-shockable rhythm. The survival rate of those patients who did not have a shockable rhythm was 0. None of them survived. And all the survivors were for the patients who had initially a shockable rhythm. It's probably also a good indication of what should be here the group of patients who might benefit the most from that kind of treatment. Other data from France here, from our hospital in La Pitié-Salpêtrière in Paris, 51 patients. It's from close to 10 years ago now, when we decided to evaluate the interest of that kind of activity. At that time, the low flow time was very long. On average, was close to 2 hours here. And in that series, we did only have 2 survivors, so the survival rate was less than 5, and it's probably once again because of the long time from collapse to the time the ECMO machine was functioning. And since that, we have restricted the indication now, and we deny the indication if it's not possible to set up the ECMO machine within 60 minutes of collapse. So once again, it's probably very important to scoop and run the patients very rapidly to the hospital. So let's discuss now the improvement strategies, because obviously there's many patients who are actually dead. You may find a lot of these so-called patients in cemeteries, and I guess it's not useful to set up an ECMO machine in this population of patients. So we need to define the population of interest. The age might count for sure. The age limit might be the age limit for transplantation for the beginning, and then might be extended a little bit depending on the comorbidities of the patient. But for a patient which is over 70, maybe 65, I guess this might be useless. On site, it's very important that the patient was witnessed when he had cardiac arrest. The no flow time should be for sure less than 5 minutes, and the lowest the better. And the third point here about on-site is the patient has received bystander CPR, because it has been shown that it makes a huge difference in the outcome of the patient. Cardiac arrest should be of presumed cardiac origin, and very importantly here, the initial rhythm should be shockable, because if it's not shockable, the probability of survival decreases a lot. And initially, if you want to set up a program, you should clearly focus on the patients who have initial shockable rhythm. And okay, you might also monitor the entitled CO2 to make sure that the initial CPR was efficient. It might be also useful. But in my view, probably the most important point here is the time from collapse to ECMO time. To ECMO, the time the ECMO machine is fully functioning, once again, this time should be less than 1 hour, maybe less than 50 minutes. So this is the way it works here in Paris. The firefighters usually arrive on site within 7 minutes. The emergency services are on site within 16 minutes, and usually they leave the site after 1 hour, so it's too late. If you think about the prognosis of these patients, and it's only by decreasing this low flow time to, let's say, less than 50 minutes that we might improve the outcome. So there's 2 ways to do that. This is data from the SAMU of Paris, which is the emergency services of Paris, and they have set up a program for out-of-hospital cannulation. They have an ongoing randomized trial checking up the efficacy of that technique, and here they have published their first experience with that strategy. Clearly, it's feasible. The problem is that, is it reasonable in terms of resources used to set up eCPR outside the hospital? This should be evaluated in the coming years. The other strategy is to rush the patient to the hospital. These are data here from Dr. Yiannopoulos in the University of Minnesota in the US. And they have evaluated 2 period of time. The first one, there was no ECMO available, mortality was 85. And they designed an eCPR program, transferred patients with refractory VF to the cath lab. In the cath lab, they set up an ECMO machine. They opened up the artery, which was responsible for the cardiac arrest in most of these patients. And the mortality with that strategy dropped down to 55. So it's a huge benefit here, but also a very careful selection of the patient population. So there might be room for early eCPR, and maybe also together with early PCI in a very specific group of patients here in the chain of survival. I did not mention that, but there might be also possibility to use ECMO after ROSC when the patient arrived in the ICU for those patients who have post-resuscitation syndrome and cardiac failure in the setting of this post-resuscitation syndrome, but it is another story. So the guidelines have evolved a little bit now. It's mentioned from the latest that eCPR may be considered, but clearly we lack data to have a stronger recommendation. It's only a 2B recommendation, and these guidelines also asked for clinical trial to be performed to confirm the interest of that strategies. Jan mentioned that the studies ongoing, and these are data from a paper we published a couple of months ago about what should be the research agenda for ECMO in the future. And clearly we mentioned that one of the major trials, the top 10 to be conducted in the next years is studies evaluating pre-hospital versus in-hospital, or in-hospital versus no ECMO in these patients with refractory cardiac arrest. And one very important point here, the endpoint of interest should not be only mortality. We should focus here on the neurological outcomes in these patients, because it's useless to have a patient survival with a major neurological sequela. So this is my conclusion here. Yes, it's possible to rescue patients with refractory cardiac arrest with ECMO. The time from collapse to the time the machine is fully functioning is probably one of the most important predictor of the outcome. Initially, we should clearly select the patient, patients who have witnessed cardiac arrest, very short, low flow, no flow time, and patients who have a shockable rhythm. I do believe that we should scoop and run the patient very rapidly, as it's done in Japan, for example, or in Minnesota. But the last point is that we need research, we need more data to confirm what is the outcome of these patients, what is the cost also of this technology. And my last slide is the same as the slide where Jan showed you a few minutes before. It's an invitation. Please come to Prague, where we'll discuss all these issues together with all the aspects of the extracorporeal life support techniques used in critical ill patients. Thank you very much.
Alain, thank you so much for this very clear presentation. You very nicely addressed all the risk factors that are associated with adverse outcome, and so to say, produced a set of very valuable inclusion suggestions, which patients may be suitable for this kind of still experimental therapy. And there's a lot of questions coming from our participants again on the inclusion criteria. And just to maybe start the discussion up, I'd just like to repeat what I learned from today's session. So we are looking for patients who underwent witnessed collapse, who have a no flow time of less than 5 minutes. Ideally, they underwent bystander CPR. They should have a shockable rhythm. You can monitor the ETCO2, which should be more than 10 millimeters of mercury under CPR. And you should, by all means, look at a time between collapse and start of ECMO of less than 30 minutes. So I think that has become very clear. Now, I have a question to both of you. Maybe start with Jan. You went through this process of building up program that is in effect now, and I picture that there's a lot of participants out there who would consider doing the same thing. Can you just tell us a little bit about your experience? What is important? Whom do you want to be in this team? What are the first steps to bring people together and build up the structures to really have a functioning eCPR program?
Yes, the first thing which has to be clearly defined is that eCPR is just the top of the iceberg of the whole ECMO program. So first, if you want to start eCPR program, you have to run an ECMO team within the hospital to be able to take care for ECMO patients, and I mean both VA and VV ECMO patients. So this is prerequisite. Then the routine ECMO patients have to be frequently admitted to hospital, both as retrievals or patients coming from cardiac surgery, coming from cath lab with cardiogenic shock, and similar ones. So this is a prerequisite. Then after you have a established ECMO team able to take care for, you can start with cardiac arrest. And sometimes, the life is faster than the circumstances. So what's happening is that there may occur a cardiac arrest, and optimally it's the cath lab where we are able to cannulate easily. And those patients with in-hospital cardiac arrest who have a refractory being properly resuscitated immediately in front of the witnesses, those patients may benefit most. So I suggest first to be able to start a eCPR team or just an ECMO team members who are able to be at the place of cardiac arrest within 15 minutes of alert. This is important to be well organized, so to know the number, whom to call, who is able to cannulate, who is able to coordinate things. And after you have such kind of, let's say, flexibility to be able to care for patients, you can start with cardiac, out-of-hospital cardiac arrest. And as Alain pointed out, this is probably the most difficult population. It's very difficult to recognize based on a very limited number of information you get during the phone call with emergency service to decide whether the patient to put on ECMO or not. So the prerequisite of successful eCPR program for out-of-hospital cardiac arrest is very close cooperation with emergency service, and actually to be able to transfer as much as possible of information during the CPR on site, with high percentage of layperson CPR, possibly with high percentage of telephone assisted CPR by a dispatch center, and then the current status and short transport time as pointed out.
Okay, Alain, any things you would like to add on this topic on how to start an eCPR program?
Oh no, I think Jan summarized what is very important here. I would maybe also insist on the need to go for first an activity of in-hospital cardiac arrest, and mostly around the patients arriving in the cath lab, those patients with acute MI, because it's the population of patients who might benefit the most, and then extending maybe a little bit the activity around the hospital, and when you have succeeded in rescuing some of these patients with in-hospital cardiac arrest, synchronized with the emergency services to set up what should be a successful plan here for rescuing these patients. But the key to success here, as Jan mentioned, is the rapidity of transferring patients and the optimization also of the CPR during transportation. Maybe CPR machines here might help a lot also in having successful results. So once again, first set up a successful ECMO program in your center. Try to develop the activity for in a hospital. You should be available 24 hours a day and even during the night, and being able to set up an ECMO within 20 minutes after the call. And then if you succeed in that activity, then you can think about working with other professionals, and clearly here it's the emergency services to set up an out-of-hospital cardiac arrest program.
Okay, Alain, next question also to you. What's the role of immediate or at least short-term revascularization strategy in a patient with a shockable rhythm? When will you take your patient more or less immediately to the cath lab? And what is the patient where you say you rather wait for the patient to cool down and do the semi-electively maybe at a later point of time?
So the strategy showed by Jan is also the strategy displayed by the team from Minnesota, is to set up the ECMO in the cath lab for these patients. And when the ECMO is set up, first rescue the patient, then rescue the heart. When the ECMO machine is fully functioning, then it's time to reopen the artery, because most of these patients will have acute coronary syndromes. So I think it should be done as soon as possible. You might also cool down the patients, but most of these patients coming from outside the hospital, when they arrive in the cath lab, the body temperature is usually between 34 and 35. So usually they also have been cooled down just by the fact of having out-of-hospital cardiac arrest. But it's very important, and that is a few series showing also the positive impact of very early PCI in these patients. So there should be a strategy, ECMO first, because you have to rescue the patient, and then when the patient has been stabilized on ECMO, very rapidly perform PCI.
Okay, Jan, there's quite some questions from our audience on cannulation strategy. So can you just share with us how you choose the site, what size of cannula you choose, what is the technique, how do you access the vessels, and how do you immediately ensure the proper placement of cannula? We can't hear you, Jan.
Sorry, can you hear me now?
Yes.
Okay, sorry. Yes, when the patient arrives to cath lab, first we very briefly confirm eligibility, and we confirm that the patient still has a cardiac arrest. And then we start, we put the patient on the cath lab table, we clean the groins. We always use the groins as the first access point. And what I do, and I would like to stress that before we actually started the randomized trial, we have been practicing this for more than 2 years together with emergency service, and we have treated more than 15 patients or almost 20 patients by this before we dare to start the randomized trial, to be sure that those operators who perform cannulation are really experienced ones. And this is logistically extremely difficult because you must not have too many of those who are actually performing the cannulation, because you have to keep the expertise. So at the moment we have basically 4 people doing this in our center, and we are trying to cover 24/7, and it's not so easy every time. But anyway, when the patient comes in, I start with the blind cannulation, and I have my ultrasound available. If it's not successful at the first trial, I always use ultrasound to find the vessels. But it's not easy. During the CPR, everything is moving, and it's not so easy to find the proper vessel. And then there is a couple tricks how to do it, and I will let those tricks for EuroELSO, but because I need to show some slides to share those tricks, you have to go a little upper than we usually go, and how to recognize whether you enter the right vein or right artery. It's again not easy. Patients are hypoxic, they have no blood pressure, the flow from the needle, if you insert the needle into the vessel, is the same if you enter artery, it's the same if you enter the vein. So we orientate usually based on the wire which has been inserted. And one thing is extremely important. Before you cannulate the cannula inside a patient, you have to be 100% sure that you are in the right position in the right vessel. So what I do in all patients, I do brief angiography, look at the vessel, how the vessel looks like, whether I'm in the lumen, and whether there is no dissection, and of course the diameter of the vessel is nicely seen. And then I choose the cannula. There are centers using smaller cannulas. We use the reasonable cannulas, meaning in women 17 French is usually enough, 19 sometimes. In males 17, 19, 25, 21 French cannulas for artery, and in for the veins respectively 21 for women, 23 to 25 for males. It's usually enough.
Okay, thank you. Thank you specifically for hinting at the cannula size of the veins. I've seen several cases myself where you just couldn't get enough flow, and when you looked at the cannulation, oftentimes you have the feeling that the vein was chosen too small, and that's also one of the questions that one of the participants referred to. So I think this is something you always have to look for in order to assure a proper flow. Question for Alain. When you set up the system, you maybe took care of the heart, you looked for the right revascularization strategy, and the patient is more or less stable. In the next hours and days, how do you monitor the neurologic outcome and the progress of the patient?
So most of these patients will be deeply sedated for, let's say, at least 2 days. We usually perform brain electroencephalography as soon as the day one to detect convulsions in these patients, and this is the first step. Then usually after let's say 1-2 days, if the patient has been stabilized, and this is not very easy to stabilize most of these patients because they have the so-called post-resuscitation syndrome, and most of these patients are very, very sick. They have major coagulation problem, renal failure, liver failure, so it's very difficult to evaluate them because they need sedation for some time. When it's possible to decrease the level of sedation, obviously, then it's going to be the clinical examination, which probably is the most important point here. And when the patient is weanable from the ECMO machine, we usually go for a brain MRI with the so-called functional MRI, which now makes it possible to detect the complication following cardiac arrest. This is still experimental, but we have very interesting data to predict the outcome, neurological outcome of the patient who did have cardiac arrest, whether they receive eCPR or not. But usually you may wait at least 1 week before evaluating these patients with the functional MRI.
Okay. I see that we have 2 more questions today, and the next one is, in my opinion, kind of a tricky one. I would like to start with Jan on this one. It's about the problem of afterload reduction on ECMO and the use of a balloon pump. How do you see the role of this kind of device in connection with the veno-arterial ECMO, and how long would you at all tolerate minimal or no ejection flow conditions over the aortic valve while the patient is on BA ECMO?
Okay, there's several considerations, and this is not easy. First, I'm kind of conservative in those patients, and I try to avoid any intervention after eCPR. First. Second, basically in eCPR patients, not too many of them need unloading of the left ventricle. Third, and there are some centers which use unloading of the left ventricle quite frequently, but we don't, and I may explain later on why. Third, the most important is to assure enough blood flow for end organs. We have performed a microcirculatory study published last year in SIO, showing that ECMO actually is able to sustain enough perfusion of respective tissues, both in patients who do have pulsatile flow and also in those who have not a pulsatile flow. This is important. ECMO works well. And when we consider unloading, it's very easy. There are some centers, and I consider this to be very clever. They measure end diastolic pressure in the left ventricle. So during eCPR, when the patient is in the cath lab, they just insert inside the left ventricle the pigtail, and they measure the end diastolic pressure in the left ventricle. And if it's high, they use some measure of unloading of the left ventricle. First. Second, the main problem with the low pulsatility is first pulmonary edema, which should be avoided, or at least should not be tolerated for a long time, because if it's for a long time, you will get a severe lung damage and the patient dies usually. And the second one is the risk of a clot forming in the left ventricle. So if both of those things are pertinent, we use unloading of the left ventricle. At the beginning, we used pigtail catheter for extraction from the left ventricle. It doesn't work. And at the moment, we use either surgical unloading or impella combined with VA.
Okay, what do you, can you briefly explain what you mean by surgical drainage?
Yeah, it's from the small thoracotomy, and the cannula is inserted through the pulmonary vein into the left atrium or left ventricle, and being connected to venous part of the ECMO. But we are, as I said before, we are trying to avoid any intervention, both, and I mean both the interventional and surgical. So if not necessary, we never do this.
Okay. Are there any different strategies in Paris, Alain, on this topic?
Yeah, slightly different. We have worked on the impact of the balloon pump over the last 5 years. We did first physiologic study that showing that it works, especially for those patients for whom the end diastolic pressure was elevated at baseline. So now our strategy is to go for the balloon pump as a preventive strategy. It doesn't work if the patient has already developed massive pulmonary edema. But if you set up the balloon pump together with the ECMO machine early on, you might prevent up to 80% of the severe pulmonary edema occurring in these patients. So our strategy is to go for the association of the two devices for, let's say, up to 90% of the indication. And from our experience, those patients for whom the risks are higher is those patients with no residual ejection or very little LV ejection, patients who have dilated ventricles, and those who have dilated ventricles, they also have some kind of mitral regurgitation, which is quite significant as a function of the dilation of the left ventricle. So in these population of patients, it's almost mandatory, and I would say it works in up to 50% of the patients. For those patients who do not succeed to be protected, we usually switch to the impeller. We have tried also many strategies of direct LV venting, but it's very difficult. There's a competition between the drain from the venous side and the left ventricle. We have a lot of problems with the collapse of the line draining the blood directly from the left ventricle. So in our opinion, first line, the balloon pump, and for those in whom it doesn't work, switch, remove the balloon pump and insert the impeller. The CP is working nicely. It's very expensive. It's working nicely.
Okay. Jan, last question. When do you declare an eCPR case as being futile?
Yes, usually when we confirm the severe brain damage, which is quite often, but it's not always easy. There is a large controversy how actually to prove the brain death on ECMO. And there is being a consensus paper being prepared by EuroELSO for this issue by the group led by Nick Barrett and others from the steering committee. So this is important, how to examine actually a patient, how to examine brain perfusion. Second, we use other markers for neuroprognostification, the same as are being used in regular cardiac arrest patients, recommended by ERC, including NSC levels. For determining the brain damage. And if we prove either severe brain damage or brain death, we just stop the ECMO machine, like a terminal weaning, and we wait what happens. And we always call the family, and we do it with the conjunction with family, and we let the family be inside the room.
Okay, so the last word is for the president. Alain, anything you would like to add on this point?
No, first I would like to thank all the people, physicians, and all professional joining this session. There was quite a lot of people joining this first webinar, and this for us very encouraging, and we will have more in the coming weeks. So stay tuned. We will advertise that on our website, and you will also receive invitations through the website and through the emails. And my last word would be the invitation to Prague. It's still possible to register. You have to do it in the coming days. The Congress, which has been organized by Jan, is going to be very successful. A lot of sessions, very interesting, prime time results of many tries. So please come, please come to Prague.
Okay, so thank all of you for joining this session. Thanks to our experts. Thanks for all of the participants to being very active and sending in a lot of questions. As Alain said, there will be a series of webinars. There will be approximately one per month. So again, just stay tuned with EuroELSO and keep on learning with us together. Thank you so much for joining today and have a great day. Bye-bye.
Thank you. Goodbye. Thank you.